Okay, welcome everyone to this episode of your Freedom Hub's Free Market Cash Patient. I'm your host, Jeff Cantor, along with Charles Froman. And as usual, we are being sponsored by the Freedom Hub, where we are, in fact, the disruptors intersection. We're at our key website. We'll come over there and do a tour momentarily. One thing to point out is we do have an issue in the healthcare market. For those who didn't understand it or even know what the problem is, this little cartoon makes it fairly obviously where our problems lie. As a consequence, there's some great tools that are a part of becoming free and getting this market back in line, and one of which is one of the key things we're talking about here tonight, which is the WOW app. We have a great site to take a look at it at, and we'll take a look at that for a quick minute. And again, you're going to want to start out by visiting us at our main site. This is kind of the short initials to get there. To give you an idea, when you do pop over there, we've got a lot of really interesting things where you can learn and find out about a variety of areas. As a bit of a tour, we do have a number of organizations and many more joining regularly that are really fighting on a lot of fronts for your health and financial issues. And we've got some information about a variety of them, give you a chance, and some great videos and the like. And then also, as I said, there is this revolution in healthcare. And so this is one of the key tools, which is the way to kind of connect the doctors and patients and bypass that whole insurance metric. Or, as we'll find out tonight, have a way where they actually work together for a change instead of us trying to escape from them all the time. And then here's that site that we showed before. And then we do have our webinars. So the way to find out about them is when you're at the website and you're on the home tab and you come to the webinar one. This is where we're going to have the information about the show you're on tonight and others. So we do run a couple different shows. And then most importantly, I'm scrolling to the bottom because you'll see there's links to each and every one of these series on a variety of different platforms. So we're, as an example, on BitChute or Brighteon or even on Rumble. So we're in a variety of great places. And then after the show, there's a way to continue the conversation where you get to stay connected with the speaker and help them move their project forward as it makes sense to you. So this way, it's just not like we're one and done. We hear from our guest tonight and then we just kind of all go away to our separate corners. We can actually engage. So with that in mind, let's find out about what's going on tonight. And I'm going to give Charles the privilege of breaking out who's here tonight and what we're going to talk about.
Thank you, Jeff, and welcome, Abbas. It's a thrill to have tonight's topic because a few years ago, Jeff and I were featured in Forbes for one of the better Obamacare alternatives, packaging a sharing community with a health savings account and turning patients into cash shopping patients, which the reformers like, because you have to have patients shopping around on price to get any real impact on the supply of healthcare. We thought insurance was shot. And then we met Abbas, and he is going through the ringer with the insurance bot commissioners in the States, trying to restore insurance to what it traditionally was before all the politicization that ruined that market. And not only is he trying to restore insurance as a true protector against unforeseen catastrophic expenses, but he wants to do it in a way that allows doctors and patients to choose their treatments and not be hassled with pre-authorizations and all the usual third-party interference that gums up the work. So it's really revolutionary what he's trying to do. So a lot of folks are really excited about Abbas's project. Real quick background on his LinkedIn. He shares a bit of the background Jeff and I have, I guess, with politics. At Columbia years ago, Abbas, I don't want to age you, he has a poli-sci major and a master's in international affairs. And like me, it looks like he got an education as a school teacher. He got his doctorate. I have my master's. So I guess there's a bunch of politicians and educators in this horrible health cartel trying to educate us on better options. So that's our intro, Jeff.
Well, that's pretty exciting, I would say. So let's give the screen over. So I'm going to stop sharing from my end. And now, Abbas, if you'll go ahead and share your screen.
Okay, everybody
There
see
we
it?
go. Yes.
Great. Thanks very much for inviting me, and I'm very glad to be here to talk about the subject that is very critical from all respects. And I would ask to just underline what Charles said, that in fact there is nothing symbiotic about insurance and healthcare. So it's critical to understand exactly what insurance is and what the mechanism is to be able to then shrink it to what it should be and consequently reduce the cost of what is a simple claims payment system and just administrative.
Okay.
So just a quick description of what insurance is. Essentially a mechanism for sharing risk and its cost among a specific number of people over a specific period of time. It's centuries old, and Lloyds of London is a prime example. Historically, initially, it was simply connecting people with money to people who wanted to pay an amount to protect themselves against catastrophic risk. And it was mainly with the East India Company and various merchants getting on their boats, going to the India and then bringing stuff back. So essentially, it's a universal concept mechanism, and it can be used to cover any underlying risk. Sports people, insure various parts of the human body. Piano players insure their hands. You can insure anything. You think of something, and as long as it's an event or it's an incident that can happen, then you can get a price for it. Which also means that it's got nothing to do with the underlying risk. And it's completely devoid or separate from it. However, it is a mechanism best suited to covering rare intermittent risk events. They can be measured statistically and predicted for the future. That is very important to understand as regards health insurance. And it's also very empirical. It is governed by the rules, I should say, laws of statistics relating to incidents, history of risk to be covered, and probabilities. And essentially, if you have enough data points and over enough period, you can be super accurate, able to measure variances to almost any degree. So it's the laws of statistics, the history, the costs of potential risks, and the number of people covered by the risks that will end up determining the cost in the form of premiums that each member of a group has to pay in order to buy that risk coverage for the entire group. That is a key financial element in insurance. So you simply have to know what your aggregate risk is, not your individual risk, your aggregate risk, and then divide that by the number of people you're covering to see what the minimum charge you need to have to protect yourself in a statistically significant way. Now, it's also important to know, and obviously you all know it, but how healthcare works in the US. Now, as we all know, the US has never had a government-sponsored system for providing or for paying for healthcare. It's always been private and commercial sector of activity. Of course, we've got the exceptions of Medicare and Medicaid, but those are very specific for retirees and then for poor people who simply have no means. Now, this is also important. Healthcare has two components. One is just the wellness preventative care, which everybody undertakes. It's like, you know, taking your car in for an oil service every 5,000 miles. And the other one is catastrophic care. You get cancer, you have a heart attack, etc. So the first is frequent, very inexpensive and routine. The second is very rare, intermittent, and very expensive. Now, as you probably will realize, wellness and preventative care are not inherently insurable events. They are regular, it happens, you know it's going to happen, they're routine, and they don't cost enough to warrant a whole system of insurance. Catastrophic events, on the other hand, are very suited to the insurance mechanism. In fact, more suited than most things, because there is a great amount of predictability in terms of the catastrophic events that happen. Lots of history, lots of experience, and to the point where you can predict with 99% accuracy how many people are going to get cancer in a year, at what age, at what age groups. So it is a quintessential insurable product. Now, also because of this lack of government involvement, such as exists in England or in European countries or the East, paying for healthcare is essentially up to the individual people. So when there's no program where you can just go to a doctor and go home like you can in England, and the doctor's on the payroll of the government, or the hybrid systems in Germany, etc. The doctors get paid automatically by the government. The result of all of this kind of political and social economic developments in the US has led to what health insurance looks like today and how it is developed. Now, as you all probably know, and this may be redundant, insurance essentially for medical events essentially started through the initiative of doctors and hospitals who were looking at ways to help their patients pay for their services. Blue Cross and Blue Shield is the manifestation of those attempts, and they were essentially created as non-profit entities to cost as little as possible, but to allow people to be hospitalized, to have insurance. And it developed in the US as state-by-state based system. So every state had a Blue Cross and Blue Shield. And you got it, and there was very little competition. Very few other insurers got into it. And it was not considered a commercial activity. And I don't think healthcare was considered a commercial activity at the time. However, now, during the course of many years, and all the privatizations that have taken place since the Reagan era, this simple, cost-effective, and proper insurance product was replaced by a private sector initiative. supported by government action that was very complicated. And ultimately, because it was sort of privatized and then private companies, its only motivation became to make as large a profit as possible. So reducing the whole exercise to a zero-sum occasion. And the insurance companies wanted as much of that sum as possible. Now, driven by profits, and a lot of these companies are public, which means they have to pay attention to their top line and their bottom line. They have to be constantly growing. So these companies, insurance companies like Anthem and Humana and United and all the Blue Cross, Blue Shield, even non-profit making supposedly, look constantly to increase the top line, which are the premiums, and reduce their costs. That is healthcare. That's normally what a commercially driven, profit-driven company does. So Coca-Cola tries to reduce the cost of its ingredients and sugar and plastic and labor and everything else, and charge as high a price as they can. And the difference, of course, will end up being the gross margin, which will allow for as much net profit as they want to make in order to keep their stock price growing. Now, because it's a typical commercial model, the insurance companies had to increase their revenues and constantly decrease their costs, because the market, so-called market, demands constant growth of both top line and bottom line. So they had to devise mechanisms to limit how much money they had to spend on care for their members and to increase how much money they charged their members. And obviously they used what we see today, which is cost sharing, narrow networks, drug formularies, pre-authorizations, and all kinds of other elements which are nothing to do with insurance and nothing to do with healthcare. So this has all led to where we stand today, which is a status quo which is unsustainable. Everybody recognizes that. Unfortunately, nobody recognizes why. The health insurers have created an insurance mechanism which no longer respects the principles and rules of insurance. They are selling a model that combines the two elements of healthcare events into one, a statistically impossible task. You just can't do it. You cannot add an uninsurable series of events to insurable events and kind of finish in the middle from a statistical point of view. You just can't do it. You know, it's like the laws of gravity. You just can't get rid of it. Those wellness and preventative care events that are not insurable are removed from the insurance formula by these insurers. I mean, they're pretty nasty types. Through deductibles, cost sharing of various sorts, etc. And they've passed that cost on to the member. The catastrophic events are covered as insurable events because they are, but they mitigate the cost, again, through various cost sharing mechanisms. So they essentially do not cover the whole thing as they should. You know, it's like a car insurer saying, okay, if you actually have a catastrophic accident, your car is destroyed, you're going to have to pay half of it yourself, which doesn't happen. There's a 500 deductible and that's it. So we now have this situation where providers are underpaid, members are forced to share in the cost through cost sharing, while the insurers charge premiums on the premise of covering both elements of medical events and healthcare utilization. And crucially, something seems to have happened here in my PowerPoint. Let me just try to remember. Anyway, so let's forget the and crucially, and then go to the next one. So they have to try and justify all of this. They have reinvented themselves as being at the head of healthcare provision and the gatekeeper for everything, supposedly protecting the member and reducing the costs. This is the ultimate con perpetrated on the American people. And it costs the American public close to $500 billion in overcharges. Now, to kind of substantiate what I'm saying, there's some data that is very interesting to see. Based on a data set from IBM Health for 166,000 commercially insured people in Delaware, in 12 months, there were 4,706,037 units of medical service used or provided in 12 months. This TrueVent study captured all the data for these people based on commercial health insurance through the entire process of claims, all the claims, broken down in the categories that the codes and the diagnostic things. Now, it's very, very interesting to see that of these 4.7 and so million, only 0.002% was for inpatient services, with an average cost of $17,195. So these inpatient services were with surgery and or without surgery. Now, it essentially represented only 5% of the population that were insured if you took it by individual, and represented a tiny measure of people. It's actually 8,000 units of utilization in an entire year for 166,000 people. Now, 14.6% was for outpatient services, which includes outpatient surgery, by the way, with an average cost of $338, because the outpatient services includes, diagnostics and things like that. 57.8% was for professional services, and they had an average cost of $96. 27.8% was for prescription drugs. 74.5% of those were generic drugs at an average cost of $33. So fully over 80% of all medical service units fall in the category of wellness preventative care, which are routine and cost less than $100 a unit. So essentially non-insurable events, cost events. Only 8,000 units over the entire 4.8 million numbers are actually catastrophic events, which are insurable. Now, to put this in perspective, in Delaware, Highmark, which dominates the market, charges on average over $650 per month per member for small group employer-sponsored health insurance. The average cost sharing is over 20%, which actually amounts to more than $5,000 annually per person. According to their own filing, which they're obliged to do with the departments of insurance every time they want to renew policies and get their rates approved, their average allowed claims range. Allowed means what the provider can expect to be paid in full, irrespective of what they have invoiced, ranged between 412 and 489 per month per member, depending on the most popular metallic values, which tends to be silver. Their paid claims, which is actually what they paid, range between 351 and 411. And obviously the difference between these two is the cost sharing. In other words, the amount of risk that they're foisted on people. So if you figure this out, then you see that 650 a month is something like 7,800, 8,000. You add the 5,000 to it, so 13,000 bucks goes to the insurance, is actually benefiting the insurance companies. The 650, which is about 8,000, is a premium, and the 5,000 is a cost sharing that they're supposed to cover, and they've hoisted onto the consumer, even though they pay as little as $351 on one of their most, a plan which has a much higher deductible and maxes out the out-of-pocket expense, and 411, which probably is a little bit lower than the max out-of-pockets. So as you can see, the equation just doesn't make sense, and they use all kinds of marketing, all kinds of fear-mongering, all kinds of nonsense, mistruths, false facts, everything that everybody's claiming everybody's doing these days to fool people. And of course, healthcare is it's both necessary and life-threatening. People are all too aware of somebody who's died from cancer, or who's who becomes invalid, or who suffers from heart issues, or has some kind of chronic debilitating illness. So the insurance companies make sure that everybody's aware that if you don't have health insurance, you're going to go bust. Now, as I said before, and I explained, health insurance is very, very simple. It's a mathematical formula. It's driven by rules. So you really can't go wrong in it. So we should have a solution that's simple. We should go back to using insurance as intended, as a mechanism to share risk and cost. We should separate the wellness and preventative care services from the catastrophic ones. We need to develop the cheapest way to pay for the routine services, because it doesn't make sense creating conditions and circumstances and differences just to pay 80 bucks or 90 bucks or 100 bucks for a quick 15-minute visit. And anyway, you can't insure it. So you're much better off understanding what that might cost you in a year and coming up with a simpler system of just paying it. For the catastrophic events, because they are so few, so it's only 50 people out of 1,000, have a system where you literally negotiate with multiple hospitals, like your Freedom, services, come up with the best price and the best quality for the inpatient services, pre-negotiate and come up with a fixed initial price so that then you can pay it simply again without all the complications that today exist, since hospitals provide 15, 20 different billable events, which is irrelevant to insurance. Insurance wants to pay the total cost. So negotiating a one price for a whatever medical event. Now, you might talk about emergency and stuff like that. Well, 95% of all hospitalizations are planned. So there will be some element of unknown, etc. But again, those can be negotiated post-fact. Because they're so few, you can devote adequate human resources to fixing it. Now, in order to also reduce further the complications and the needs for all kinds of administrative support and documentation, you just have an open network so people can go to whoever they want to go to. You get rid of pre-authorization so that the doctor treats the patient. You don't have a drug formulary because the doctor will prescribe the best medicine. Doctors are sworn to doing no harm and protecting life. And they're a lot better than insurance idiots to decide what drug should be used or what medical intervention should take place. This will further free the doctor-patient relationship, because sometimes, like you all have understood, you get direct primary care. So for an insurance company, having direct primary care is the optimum solution for these wellness issues. So if I, as an insurance company, say, okay, my member, if you're willing, we'll sign an agreement with Dr. X. We'll pay Dr. X 50 bucks a month, 60 bucks a month, and you visit that doctor whenever you want. And the doctor will decide what your next treatment is, if necessary. So essentially doing what Freedom Hub does, okay? Say, okay, we create this direct relationship. The doctor and the patient decide everything. The patient goes wherever the hell they want. And the providers, except for hospitalization, will get paid instantly. And in fact, we have developed a mechanism of virtual credit cards where our patients, through our app, will visit a doctor, come out, what's it cost, 100 bucks, gets through the virtual credit card, gets authorization and pays that patient. So it is a MasterCard transaction. The doctor gets his money, within whatever it is, 24, 48 hours, and just gives a receipt, just like any credit card transaction. That's it. No more paperwork, no more codes, no more level 3, level 5, level 6. And most of the time, we don't even have to negotiate rates because the self-pay rates are equivalent to what commercial insurers pay, by and large. This way, we ensure that the administrative and operating costs of the insurance, i.e. paying for claims, will be less than 5% of premiums, as opposed to up to 30% that insurance companies take today. Now, this, as you can see, sounds like a simpleton's solution. But that's because insurance is a simpleton's game. And the closer you are to that simplicity, the lower its cost will be. So that we can then become just like Walmart. Okay, Walmart, vendors sell products to Walmart, Walmart pays them, customer walks into a shop, buys something from Walmart, takes his credit card out, pays Walmart. All of that costs 3 cents to do, 3 cents for the payment process. It costs more for Walmart to have shelves, etc. Now, insurance, we don't have physical buildings, we don't have shelves, we don't have physical anything, no inventory. We're just a virtual platform that just pays claims. So, yes, healthcare, proper insurance is the answer to the affordability and availability of healthcare. Now, with the ACA rules and the subsidies for small groups and for individuals, essentially with no cost sharing, insurance may end up costing nothing to people who can't afford it because they don't have to pay deductibles and all the rest of it. And doctors get the full amount that they're looking for. So it ends up being a better version of Medicare for all. And one day, maybe they'll end up doing this with Medicare so that you get rid of all the complexities and reach the real solution, which is, as usual, the simplest thing and the thing that they started with 80 years ago. That's the end of the stuff I had to say. I hope it didn't take too long.
No, that was quite good. And as I'm listening to what you're describing, I'm thinking, geez, something is totally wrong with this guy because everything he says like makes so much common sense. You know, why is it not getting done? But, you know, there's no room for, like you said, excess profits. Everyone gets a double dip. Graft, there's room for graft to take place. Lobbyists have a home. I mean, you know, there's no winner in what you're talking about except for the doctor and the patient.
Right.
Which, you know, seemingly no one, we're the ones that are the paying for it, and we're the ones that need the care, and we're the least important people in the equation to everybody else. And somehow they've made the consumers think that the docs and everybody are taking advantage, that the insurance company, like you said, they're the saviors of the consumer, they're the gatekeeper, yet they're the ones that are actually the guilty party.
That's why I call it a con, because
how do you flip that script, though? And that's kind of my question. How do you flip that perspective? Because until people start to figure that out, it's going to be hard to make everything. You're not going to get some legislator or somebody else to make the right move.
No,
we have to figure that out.
Well, actually, it's much simpler than appears. Then the whole health insurance system is a house of cards con scheme. Okay, if you remove one card, the whole thing will collapse. So once our company, Delsure, and we're now in a 3-year battle with the Department of Insurance in Delaware because they understand, and Highmark understands, the disastrous consequences for them if our policy is accepted. And we're currently in the Superior Court in Delaware suing them in order to force them to allow us to sell insurance because we meet all the conditions, we meet all the elements. They've already approved what's called the business plan. Once that we have that, and we will prove all the statistics that I've given. Once it becomes clear that Highmark is charging $200 a month too much, even taking into account the costs, the co-pays and deductions, the whole thing will collapse. It literally will collapse. It'll be like what happened to the airlines. Every major airline, legacy airline, went broke. Some of them have gone bust 3 times. And the reason they did was because JetBlue and people from a long time ago said, why don't we do this simply? We go from point A to point B, that's it. You get on the plane, you get off. We don't use the fanciest airport. We don't use all this crap about, providing you this and the other thing on an airplane, which you go on to travel, not to eat, not to, think you're having a luxurious experience. And there's nothing they can do about it, ultimately, because they're far too big to react. So, yeah, once that falls, and I think it's very important that all the healthcare providers of the U.S. put enormous amounts of pressure on the departments of insurance of the various states to be open to ideas and not to push them out, which is what's happening. But we will prevail. I mean, there's no doubt, because they don't have a statutory leg to stand on. It's just the commissioner being very arbitrary. And since he's a regulator in a position of authority, he can take whatever action he wants. We just have to then react legally, go to courts. And that takes 2 years, 3 years, and costs a couple of $100,000. But I'm determined enough that we're going to do it. We go to the end.
Well, the luxury of what you're describing is you only really need to have the one success to force that house of cards to start the fall.
Absolutely, absolutely.
So you don't have to litigate 20, 30, 40, 50
Oh,
times again.
no,
Just one time will do the trick.
Yeah, and insurance actually is in fact, they use, through the National Association of Insurance Commissioners, they use all the same things to apply for what's called the certificate of authority. So the templates are identical. You just put at the top of it Delaware or Pennsylvania or California. So once you got one place, then automatically it's going to be agreed everywhere, because California can't say, hey, Delaware, because it's federally mandated, and most of the rules are federal. There are very few rules to the state.
That's very good for that purpose. Just a quickie, because we got some hands up. What is it that any of us listening can do to help further you getting that done in your state, or how do we help?
Well, I think that we the kind of grassroots movements for, your groups, your associates, your people posting stuff, whether it's on LinkedIn, whether it's on, other sites, social media, to talk about it, to demonstrate, to explain what insurance is and what the underlying costs really are, and to turn healthcare providers into the saviors that they are, because doctors save people, insurance companies. It's a noble profession. I mean, it's been a noble profession for 5,000 years. Doctors have been always the preeminent people, respected people in all societies, all the way back to the Chinese Empire and to the Persian Empire. So that battle has to happen before it's too late, because big hospital systems are now suddenly thinking, well, yeah, look at the insurance company. We can make a ton of money. Let's just all become big. So they buy everybody. And then they make agreements with the insurance companies and say, okay, great. And then the insurance companies go and buy hospital practices. And before you know it, all of a sudden, you will have socialized, what you call socialized medicine, except the government will be replaced by the insurance companies, and they will be paying minimal amounts, less than what even the government would pay, to providers who would be then employees or suppliant independents, even if they would exist going forward. So this is a real important issue. And, this is the Achilles heel they have. If we have an insurance model that actually costs what it should cost to pay claims, then healthcare sector will be the winners, and people will be the winners. And insurance will be relegated to just paying claims and collecting enough premiums to make sure they don't go out of business. And that's less than 5% of what the cost of healthcare is, or what doctors and hospitals, etc., are paid for healthcare. And if you're at that, you have Medicare for all, which works on a much more efficient basis than any government-sponsored Medicare for all would. And it would get rid of the argument of whether medicine should be socialized or not socialized or all the rest of it.
Jeff, are you muted?
Hello?
Am I there? Sorry, I think I muted myself by accident. Yeah, hi, Charles. I said you got your hand up.
Actually, we have some pretty good attendees, Jeff, and
well, Paul's is up if we want to bring Paul in.
I want to hear. I was hoping Jawad would comment from on what he's heard, and then David Levian for getting a movement together for this. Those two I want to hear from, Jeff.
Okay, that sounds great. Well, Jawad, if you want to jump in there.
Yeah, thanks so much, Charlie, and Abbas. A great presentation, and Jeff, great job putting it together. You guys, as you guys know, we've all understood this point, right? That your routine care is not an insurable event, as Abbas has shown, and shouldn't be treated as such, and that's the only way to provide the freedom that we're talking about, no networks and so on, because you really let the consumer decide where they want to go, and they know how much it's going to cost, and they can decide based on that cost if it's worth it to pay the extra or not. And I think we at Wow Health have, of course, taken a little bit of a different approach. Instead of trying to go through the regulatory cycle, which we of course wish Abbas best of luck in getting through it, we've kind of said, we're just going to go through the market approach and develop a marketplace, and then look at some alternative products to cover those major medical or insurable events. Right? And it's quite a challenge because, as Abbas pointed out, providers on the average don't quite understand what that means. And I think, it's a domino effect. So you do need a few to fall. And I would hand it over to Dave, because I think that, Dave's group has been working quite effectively with that side of things.
Sure, David.
Yes, well, I really want to thank Abbas for an really erudite talk on the difference between healthcare and payment for healthcare. I'm really honored that Abbas is a fellow of the American College of Healthcare Trustees. And again, he has probably a more acute understanding than almost everybody I've heard speak about this issue. And I'm also very proud in interest of transparency to be on the board of directors of Delsure. But I think that their model is truly outstanding. As Abbas said, 80% or more of the transactions are low-risk transactions. They're unpredictable. They're not really statistically and actuarially relevant. And they really can be treated like buying a pair of shoes. You put down your credit card and you pay for the transaction. And in so doing, you get rid of a huge infrastructure of backroom people pre-approving an $80 office visit it's absurd. It's also a major bone of contention with doctors who often, for each doctor, they need to have a full-time employee with their ear tethered to the phone just to collect the payment. It's extremely disrespectful and responsible for burnout among some of the most idealistic members of American society. And I think, I'm thrilled that Jawad is on this call, because Jawad is an emergency physician, understands this acutely as well, and has done a great job with a truly disruptive and innovative platform. So again, I think this is a really excellent explication of the schism between healthcare and payments for healthcare. And the other thing that I think Abbas understands is that you can use some of the new bleeding edge technology, such as artificial intelligence, to red flag the few abusers of the system. You don't need a stable of people with clipboards, something that Adam Smith would call unproductive assets, because they really don't create value for the system. So again, I think between Jawad and Abbas and Jeff and Charles and Paul Roberts too, you have some very forward-thinking and visionary people. So this is a great conversation.
That's great, David. I appreciate that.
Yeah.
And the one thing you both sort of described between Abbas's approach and Jawad's, and to me, having been in business for so long and having sold health insurance to small business owners, it's the most amazing as you stand back. Doctors are like the only people, they have no say in what they get paid. Everybody else says, I'm an auto mechanic. I figure out how much I'm going to get paid an hour. But how can a doctor, like you said, is ideally really a smart person, vital to everyone, they have no say in what they get paid? Everyone else decides for them? Amazing. Your thing is so liberating, just even on that side of it, which we don't really talk about.
Let me just quickly say something to Jawad. Your system and our system are fully applicable to each other. You have a mechanism that says, well, you can pay us cash paying. We have a system that encourages cash paying, and we do it through our mechanisms of virtual credit cards and things like that. So our policy, our system does not preclude us signing an agreement with WOW and saying, okay, instead of your patient paying you, we'll pay you using the same mechanism, which is a credit card. So, and the objective for us is to work any which way that a provider wants to work. An insurance company is not in the business of dictating anything. Car insurers don't tell automakers how to make a car. Property insurers don't tell a builder how to build his house. They might say, if you have a sprinkler system, you get a bit of a break on the rates. But they don't say you have to. You can go to them with the most horrible fire attracting property and they'll insure you. You just have to pay more. So our business is to say, okay, who do you want to see? How does this doctor want to get paid? Okay, we'll pay it. You pay us a premium every month and you're covered. Nothing else. You don't pay for anything. You have no risk. You're not going to go bankrupt. You don't have to have a deal with the payment side of it. You just deal with your doctor. So, we can work. We can work an insurance company should be able to work the way the provider and the member work. they just have to pay a claim and just make sure that they're not getting, 3 claims for 1 visit, which is all very possible with exception reporting and variance analyses and stuff like that in your claims history.
Very good. Paul, I see you've got your hand up patiently.
No worries. Great presentation. Just wanted to kind of reiterate one of the things that David had said. He was mentioning flagging patients, flagging kind of, higher risk folks. That's actually, I just launched a new business called Alpha Delphi that is doing just that. We're actually building the system now that's going to identify risk in the patient population and flag those folks for medical case management in order to coordinate medical care. So I guess my question is, do you think that that could fit in with free market healthcare, that sort of system?
If anything can fit into the system. What insurance needs to do is capture all the data it has over the periods of time and develop trends. And what is very important for insurance is to understand the aggregate cost. Insurance cannot be based on individual costs. It's impossible to predict who is going to catch cancer and who's not. Now, there may be lifestyle issues that may, make somebody more susceptible. There are obviously DNA, hereditary stuff, genes that may predispose somebody, but that's really not an issue for insurance. The insurance understands that over 12 months, for 1,000 people, X number will end up getting a type of disease. That will be a fact. But what's important is to understand the aggregate cost. So if I've got 1,000 people, there will be an amount that all 1,000 people will spend on healthcare. And we know that to 99% accuracy.
But I think there's a difference between statistics and personalized medicine. The direction I'm going is personalized medicine, where using artificial intelligence, genetics, and these things, we can identify risk, specific risk, and then tailor the treatment to that individual. Now, certainly, statistically, you're right. There's aggregate risk, and there's two two different arguments. But I think the question is which direction to go in. Is it better to go in the direction of personalized medicine or in the direction of statistics?
I think they're not counter to each other. In fact, the healthcare profession has to go towards what you're suggesting. That will be part of best practices for healthcare providers. Absolutely.
Yeah, I think so.
For insurance purposes, we only need to know what our potential aggregate risk is.
Yeah.
And to just narrow everything down to us understanding that charging adequate premiums and then paying the claims in the simplest, cheapest way possible. Now, we would be willing and we should make available on our, what we have, we call it Andromeda, is our kind of brain, all kinds of services available that would help doctors better manage their patients as a service to them. The same way we will include billing capabilities on the system, but not something that we would be doing, but providing it, so that we would encourage it to say, okay, if you have this program that helps the doctor, and since we're going to be constantly interacting with doctors and developing an ecosystem, then please bring that. Please make that available to the doctors, because ultimately, the less cost there is, the more healthy the population is, the less the cost of insurance will be.
Bingo. There you go. That solved that circle for sure. I was thinking that same thing as Paul was running through that indirectly he is going to bring your costs down. So everybody gets to play in the same sandbox, and again, everyone gets to be a winner.
Yeah.
Well, I got to tell you, boss, that was great, and we're running out of time tonight, so I want to thank you for being here today.
Thanks very much to everyone.